Hello everybody, I'm Dr. Steve Lamberti here at the University of Rochester Medical Center. Welcome to my mini lecture on clinical assessment of antipsychotic drug-induced movement disorders. Now I want to start by thanking Dr. Yuri Zogby. He was the one that identified the need for mini lectures for busy trainees, and he's been the driving force in the development of this series. Now today, we're going to focus on assessment of extrapyramidal side effects, which, despite the advent of second-generation antipsychotic drugs, they continue to be a real source of patient discomfort as well as medication discontinuation. As I'll discuss, standardized measurements are readily available for measurement of antipsychotic side effects. Now, although these tools are highly reliable and they allow for quantification of movement disorder severity, their use is not always feasible in clinical practice. So in my outreach work as an ACT-team psychiatrist, I often find myself working in non-traditional settings. These include jails, shelters, and city sidewalks, where space, time, and privacy are limited. So for that reason, I developed the Combined Movement Disorder Exam, which is the focus of today's talk. First, let's clarify what we mean by extrapyramidal side effects, or EPS for short. This is an umbrella term. It encompasses 4 distinct drug-induced movement disorders as shown on this slide. Now, interestingly, when some clinicians refer to a patient as having EPS, what they usually are referring to are Parkinsonian side effects. That's kind of the connotation of EPS. But the denotation, or technically speaking, the term extrapyramidal side effects or the term EPS, they refer to all 4 types of movement disorders that are shown on this slide. Now, of the 4 types, acute dystonic reactions, they're easily identifiable and they generally do not require a standardized neurological assessment in clinical practice. Now, before discussing the Combined Movement Disorder Exam, let's briefly familiarize ourselves with each of the standard rating scales from which the combined exam was derived. Now, for tardive dyskinesia, Parkinson's syndrome, and akathisia, there are standardized rating scales that are commonly used, especially in research settings where precise quantification is required. Now, this slide shows 3 of the most commonly used exams here in the United States. These are the Abnormal Involuntary Movement Scale, or AIMS, for tardive dyskinesia, the Simpson-Angus Scale, or SAS, for Parkinsonian side effects, and the Barnes Akathisia Rating Scale, or BARS, for akathisia. Now, this slide gives an overview of the Abnormal Involuntary Movement Scale, or AIMS. So this is a 10-item neurological exam, and it requires approximately 10 minutes, depending on your level of findings, and it assesses tardive dyskinesia. Now, this slide shows a clinical description of tardive dyskinesia. It consists of involuntary, irregular chorioathetoid movements. These are most commonly seen in the orolingual facial region. There you can see chewing movements, tongue protrusion, lip smacking, or pursing of the lips. But it can also involve the limbs. You can see jerky or writhing limb movements, hyperextension of the fingers, or odd guitar playing or piano playing movements of the fingers. You can also see paroxysms of rapid eye blinking, and if the diaphragm is affected or the glossopharyngeal muscles are affected, you can also see irregular respirations or difficulty swallowing. Now, the AIMS exam, the 10 items are shown here, and they're divided into 4 groups. Items 1 through 4 involve facial movements, and that's kind of evidence of how important the orolingual facial movements are. Commonly, they are the first manifestation of tardive dyskinesia. Not always, but usually that's the first place to look. Items 5 and 6 look at extremity movements. The next item looks at truncal movements. And then the final 3 items involve global judgments of severity, incapacity, and awareness. Because in assessing abnormal movements, it's really important to know how functionally limiting they are and how bothersome they are to your patient. Those will help determine whether intervention is needed. Now, a note here, tremors are not rated on the AIMS. Tremors are rated on the Simpson-Angus scale. It's also a 10-item neurological evaluation, and again, it requires approximately 10 minutes depending on the level of findings, and it assesses Parkinsonian side effects. This slide gives a clinical description of Parkinson's syndrome. A way I like to think about it is simply the 3 S's: shaking, stiffness, and slowness. Now, by shaking, I'm talking about a 3 to 5 cycle per second rhythmic tremor, and it's typically visible in the hands. I'm going to see if I can demonstrate that for you. Even though it's typically noticeable in the hands, it may be visible in the legs, or you may also see tremor in the head or the tongue. Now, stiffness refers to hypertonicity. So this is most noticeable during wrist or elbow manipulation or with arm dropping. It can range anywhere from lead pipe rigidity, where it's so bad that somebody is unable to move, to cogwheel rigidity, all the way to just mild rigidity, which a patient may not even notice, but it's typically noticeable on exam. Now, slowness, that refers to bradykinesia, and that's most noticeable during gait and also rapid movements of the finger. Now, the classic Parkinsonian gait is a stooped, shuffling gait with reduced arm swing. If it's severe, the arms may be even held in front in a flexion posture. And also, you can see mask-like faces or reduction in facial expression. Now, this slide shows the Simpson's 10 exam items. I'm just going to draw your attention to items 6 and 7, leg pendulousness and head dropping, because both of those items require an examination table. Last but not least, the Barnes Akathisia Rating Scale, or the BARS. Now, this is the shortest of the 3 exams. It's just a 4-item exam, and it requires just 5 or 10 minutes. Now, the BARS evaluates both the objective and the subjective components of akathisia. Objective is how it looks, and subjective is how it feels to the patient. And of course, the Barnes Akathisia Scale assesses akathisia. Now, this slide shows a clinical description of akathisia. It's a subjective feeling of restlessness or inability to sit still, and it's accompanied by objective signs which are shown here on the slide. They can include pacing or bouncing of the knees, crossing or uncrossing of the legs, fidgeting, rocking, or even marching in place. Now, akathisia can and does occur independently of tardive dyskinesia or Parkinson's syndrome, and it's associated with all available antipsychotic drugs, even second-generation drugs, which tend to be less prone to causing extrapyramidal side effects. But you can see akathisia, particularly with the higher potency medications like risperidone or paliperidone. Now, it's very important to distinguish akathisia from anxiety or agitation, because often the interventions are the opposite of each other. So if you have a client, let's say somebody with a psychotic disorder who may be in the midst of a relapse and they appear agitated or highly anxious, you'll want to think about increasing antipsychotic medication. But for a client with akathisia, you want to think about maybe decreasing the antipsychotic medication or adding an adjunctive agent. So again, very important to make that call, and that usually involves asking a series of questions to try to find out what's going on in their body, but also in their head. Because usually when people are anxious or agitated, There's an accompanying mental state. They may be worried about something, they may be fearful of something or concerned about something. Akathisia is different. There's no accompanying mood state. People who are having akathisia, they describe it very physically. Often they'll say it feels like ants in my pants or feels like my body's wired with electricity. I just can't relax. So you have to ask questions to tease out the two, akathisia versus anxiety or agitation. Now this slide shows the bar's exam items. So the first item is objective, so you're looking for the signs of akathisia. The second item is subjective, so you really want to hear the patient report about how they're feeling. Also, item 3 is subjective distress, because again, it's really important when you're looking at movement disorders to see how functionally limiting they are, but also how distressing they are to patients, because that will help to guide therapy. And then last but not least, combining the objective and subjective, you'll make a global clinical assessment. Now, standardized rating scales, they have some very significant strengths, but they also have some limitations. So by way of strengths, these 3 exams are widely used in research settings, which are assessing the tolerability of new psychotropic drugs. And they allow reliable measurement and quantification of abnormal movements. But, as I mentioned earlier, they're not always feasible in some clinical settings due to limitations of time and space. Now I want to introduce the combined movement disorder exam for extrapyramidal side effects. This exam combines key elements of these 3 exams, the Ames, the Simpson, and the bars. It can be completed in 5 minutes, again depending upon your level of findings. It requires no equipment, and this exam can be performed almost anywhere. So this slide shows an outline of the combined movement disorder exam. Now the exam involves a series of 9 steps that begin the moment you lay eyes on a patient. Because often when somebody is being examined, they're not relaxed. And with extrapyramidal side effects, they're often most visible when a patient is relaxed. That is when they're sitting and talking or waiting for you in a waiting room. So observing that patient at rest is super valuable, whether they're sitting in the waiting room or standing on a street corner. I like to think that it's perhaps the most valuable part of this exam. Now the next steps should be done in sequence, and you can pick any sequence, but I encourage you to always perform the steps in the same order, because that ensures consistency and completeness. So I shall now demonstrate the combined movement disorder exam. Welcome everybody. Now I'm going to demonstrate the combined movement disorder exam with the help of my assistant, Dr. Yogbi. Now, as I mentioned in the slides, the exam begins with observation, because the movement disorders that we're looking for, tardive dyskinesia, Parkinson's syndrome, and akathisia, they tend to be most evident when somebody is relaxed. And typically people are not relaxed during examinations. So when you begin the examination and you approach the patient, whether they're sitting in an office or standing on a street corner, as is the case on ACT teams, you have an observation to kind of see them relaxed and unguarded. So that's where the exam starts. So as I approach Dr. Zogby, I'm mindful about whether there's any fidgeting, whether there's any tremor, or whether there are any dyskinetic movements. And those are usually most noticeable in the orolinguofacial area. So I'm going to look at those as I approach, and then we'll start the exam. I'm also assuming that Dr. Zogby, playing the role of a patient, I'm assuming he's a patient that I know, so I don't need to introduce myself. I'm going to start with introducing the exam. Okay? Dr. Zogby, it's good to see you.
Good to see you too, Dr. Lamberti.
Would it be okay if I checked you for side effects?
Yeah, sure.
Let me have you start by standing up and take my hand like we're shaking hands. Now what I'm doing is I'm checking for any stiffness, any cogwheeling, any rigidity, or anything that shouldn't be there. Now you notice I'm talking him through the exam. I'm explaining why I'm doing it, looking for any stiffness, looking for any rigidity, looking for any movements that don't need to be there. And you'll notice that I'm flexing both the wrist and the biceps tendon, and I'm also rotating the glenohumeral joint. So this is a very sensitive evaluation for noticing rigidity. And at this point, I'm not noticing any. So next part of the exam is let me have you hold your hands out, kind of like a sleepwalker, nice and straight. Now I'm checking for tremor. And to visualize tremor a little bit better, let me have you spread your fingers. And at this point, we're not seeing any tremor, so I'll instruct the patient, you can go ahead and relax your arms. Now, relaxing is a challenge, particularly when you're checking for rigidity. You'll often notice that patients are a little tense, and they may not be relaxed. So when I ask them, take my hand like we're shaking hands. If I notice some rigidity, I'll ask the patient, let your arm relax, just like a wet noodle or just like a wet dish rag. That gets them to relax and it'll give you a more thorough exam. So don't be afraid to prompt patients to relax a little bit. Okay? Now the next part also looks at rigidity. Let me have you raise your hands and just let them flop down, just by gravity. Go ahead and raise your arms and drop them. Now I'm looking and I'm listening. I'm looking for rebound. I'm listening for the slap. Yuri had a good rebound, good slap, okay? So the next portion of the exam, this is a little bit of the aims. I'll ask somebody to raise your hand and touch your thumb to each finger. Now this is a distraction maneuver. Some people use different maneuvers. Some people just have you touch your thumb to your finger as rapidly as you can. That's a distraction maneuver. The third maneuver is, let me have you flip-flop one hand in front of the other. Okay? It doesn't matter what maneuver you do, you're really trying to distract them so that you can observe for any chorioathetoid movements which are characteristic of tardive dyskinesia. So one more time, let me just have you raise your hand and touch your thumb to each finger. Personally, I think this takes a lot of dexterity and it's probably maximally distracting. Now while I'm doing this, I'm just observing him for any dyskinetic movements. Very good, let me have you do this with your other hand. Now he's using his non-dominant hand, also a little bit distracting. While he's doing that, Yuri, let me have you open your mouth and stick out your tongue. His tongue is midline, no fasciculations, no tremors. Very good, you can relax. Now the next part of the exam is also very sensitive for particularly Parkinson's syndrome and dyskinetic movements, and that's ambulation. So I'm now going to ask Yuri to walk a short distance from here to the door and back. Just walk as you normally would. And you'll notice that he's pivoting easily. You'll notice that there is good arm swing, and that's what we're looking to see. With Parkinson's, the characteristic gait is described as stooped and shuffling. So with somebody who has Parkinsonian rigidity, you'll typically see short steps, stoop posture, and a lack of arm swing. So this is a characteristic gait of somebody who has Parkinson's. And if the rigidity is significant, their arms are usually held in a flexion posture. So somebody who's looking like this certainly has a significant degree of rigidity, likely secondary to antipsychotic drugs. I'm trying to think of any elements that I may have left out. One thing that we mentioned in the video is that before you examine somebody for dyskinetic movements, it is important to make sure that they don't have any gum or food in their mouth. If they do, you have to ask them to remove it or to swallow it, because otherwise you're going to see chewing movements, lateral jaw movements, and the sort of things which look like tardive dyskinesia, but are simply chewing. So that's a tip to always keep in mind. Eric, can you think of any others? If not, let's do the exam one more time without instruction, just so you can see it in terms of continuity. So let me have you sit, and we're going to just take it from the top. Okay? Yuri, it's good to see you. How are you today?
I'm very good, Dr. Lamberti. How are you?
I'm well, thanks. Would it be okay if I checked you for side effects?
Please.
Let me just have you stand up and take my hand like we're shaking hands. And just let this arm relax like a wet noodle. Perfect. So I'm just checking for any rigidity, any stiffness, or anything that shouldn't be there. And again, not feeling anything at all. You're loose, limber. Let me have you put your hands out in front of you, and let me have you spread your fingers. Very good. You can go ahead and put your arms down. Okay, next, let me have you go ahead and raise your arms and just let them flop down. One more time. Put your arms up, let them flop down. Good rebound, good slap. Next, let me have you raise your hands and touch your thumb to each finger. While you're doing that, I'm just checking you for any unusual movements. Let's have you go with the other hand. Thumb to each finger. Let me have you open your mouth and stick out your tongue. Very good. You can relax. And the last part is let me see you walk a short distance. Let me just have you walk from the chair to the door and back. Just walk back and forth a couple of times as you normally would. And while you're doing that, again, I'm just observing you for any unusual movements. Very good, Yuri. So again, this exam was developed to be used in clinical settings where, because of limitations of time or space or privacy, you're not able to use the standardized rating tools, the Ames, the Simpson-Angus, or the Barnes. This is an exam which has elements of each of those standardized assessments.